This webinar is made possible by the Sentio Marriage and Family Therapy Program. Visit us at www.sentio.org. So welcome everyone to this exciting webinar on deliberate practice for psychodynamic therapy. Today, focusing on the skill of being aware of countertransference reactions. My name is Alex Vash. I am joined by my always trusting good friend, Tony Rumener, and we are extremely happy to be again with our wonderful guest expert, Hannah Levinson. Hello, Hannah. I'll just give a quick presentation here for Anna. So Hannah Levinson is a professor at the Wright Institute in Berkeley, California. She also has a private practice. She has specialized in brief dynamic therapy and supervision for over 40 years, has authored over 85 professional papers, 4 books, has released 6 professional videos with APA, and we could go on. And she is a wonderful therapist and supervisor, and we are very happy to have her.
My pleasure.
And everyone should know that this is part of a longer series of webinars. If you'd like to see our previous webinar with Hannah focused on another dynamic skill, you can go to the Sentio YouTube page and you have the full recording there. And Tony, you want to take care of this part?
Yeah, so today's webinar, the whole series is sponsored by the Society for the Advancement of Psychotherapy. This is American Psychological Association Division 29, the Psychotherapy Division. And the Society focuses a lot on providing resources, education, training, that kind of thing for therapists around the world. And we welcome an international audience like we have today for this webinar. So I recommend everyone check out the website, which is there on the page. Thank you, Alex. And the webinar is also sponsored by the Sentio Marriage and Family Therapy Program. This is a new master's program, graduate level program in California for training marriage and family therapists. So you can check that out as well. Thanks, Alex.
Great. All right, so we always like to start with a single slide, not take too much time, but just giving the one important idea to move forward, and that is making the distinction between conceptual learning and procedural learning. We could also think of conceptual teaching or conceptual knowledge versus procedural knowledge. And the easiest way I found, because I have so many instruments in my background, as you can see, is making an analogy. As all of you, I'm sure, had experiences with either playing a sport or learning a musical instrument. You all know that it's very different to read about playing basketball or watch videos of other people playing basketball versus you playing basketball and training dribbling the basketball. And so making that analogy into psychotherapy, in the field of psychotherapy, we have many, many resources for conceptual learning, reflecting about therapy models, discussing about different theories, watching videotapes of therapy sessions, and all that is, of course, essential for creating clinical expertise. But what's often missing is procedural learning, meaning learning by doing. I know some of you have had experiences with role play exercises in the field of psychotherapy. Those are usually a bit limited. So we're going to talk today and describe a method for a bit more rigorous procedural learning of psychotherapy skills, that of deliberate practice. So that's our purpose for today. Tony and myself have edited and are still editing a book series for the American Psychological Association. Each book that we put out, we collaborate with experts from different therapy models, and each of the book focuses on 12 skill building exercises or 12 deliberate practice exercises so that you can master really some of the crucial skills from each of these therapy models. And today we're focusing on the deliberate practice in psychodynamic psychotherapy book. And Hannah, I love your comment. I don't know if you want to repeat your comment on the cover for the book.
Yes, I had nothing to do with designing these covers, but as you can see, the psychodynamic psychotherapy cover is the most complex. And I think that's an accurate representation of doing psychodynamic psychotherapy.
We should note that usually we divide the deliberate practice exercises in these books as beginner, intermediate, and advanced exercises. But we soon realized that for the psychodynamic book, all of them were so rich and had so many complexities to them that there's actually no beginner level exercises in this book. All the exercises are either intermediate or advanced level, only for the courageous ones. So these are the 12 deliberate practice exercises in the psychodynamic book that Hannah and her co-authors created. Hannah, any words you want to say about the choice of the exercises? And then we'll move on to a specific example.
Yeah, we went through quite a rigorous procedure to try and pick these 12 exercises, looking at the research literature, doing surveys, our own clinical experience and wisdom. And so we came up with these 12. You know, there are certainly dozens more, hundreds more, but it seemed like these are the ones that are constantly repeated as really identifying contemporary psychodynamic approaches.
Great. So as you can see, the exercise, I mean, the rich history of psychodynamic therapy, we could probably do a handbook, 600 pages with different skills. So quite the effort to pin it down to 12 core skills. Of course, not comprehensive, but these are all essential skills for those interested in practicing psychodynamic therapy. And you'll notice that some of these exercises are not just what's called interpersonal skills, meaning the therapist talking to a client, but Hannah also focused on inner skills of the therapist, namely the focus for today, which is exercise 2, being aware of countertransference reactions. I know, Hannah, it's going to be a bit of an effort to describe why this is important. We could go on and on, but you want to give us a primer on this one?
Sure. Well, you know, Freud started off, we always have to start off with Freud. Freud started off in 1910, actually, describing what he called countertransference reactions. And these were the therapist's own dynamics, conflicts that were inappropriately foisted or could be foisted on the poor patient. So these were considered deleterious to doing a good therapy. And Freud said you need more analysis to eradicate these, or at least be able to manage them. Now, our contemporary view of countertransference has really changed. We see the ubiquitousness of all of these reactions that we have to patients. It's one human being relating to another human being, and we have these pushes and pulls that get exerted. Of course, we also have our own unconscious, unworked through difficulties, issues, dynamics. But more importantly, these are really pulled on, pushed on by the dynamics of the people we're working with. And so from this point of view, both research indicates and our own clinical wisdom shows that working with countertransference, being aware of countertransference, leads to better outcomes with patients, leads to better processes. I know for myself, it really helps me figure out what the case formulation might be with this particular patient as I'm interacting with them, as I'm getting pushed and pulled by them. I call these reactions, in contrast to Freud's idea of classic countertransference, I call these reactions interactive countertransference. Sometimes they're called complementary countertransference. And they're extremely important for formulating the case, assessing progress. You know, does your countertransference shift as you're working with that case? And for anticipating certain reenactments. So like if you're aware of having those feelings, those urges, those visceral kind of tearing at you, then that informs you later on when you see you might be acting it out with the patient in the give and take of the session. So it gives one a heads up, if you will. I could go on and on about it. I love talking about this topic.
As do we, I'm sure. So there is one major question, though, in context with this webinar and this book that you created. And that is what you mentioned, Hannah, that countertransference traditionally has been addressed in the therapist doing their own therapy. That's one of the main vehicles to address or to manage one's countertransference. But we're proposing something a little bit different here, that another venue that could complement one's personal therapy is through experiential delivered practice exercises, meaning you can practice a skill to hone in and manage and process your own countertransference. Maybe could you just say a few words about the difference, I guess, and the potentials of using a skill to work on oneself?
Right, right. So again, here's where the research indicates that the more we're aware of what's going on within ourselves, the better able we are to manage that countertransference, to use it on behalf of the patient, and we have better outcomes and processes in doing that. So actually getting in touch with all of that, as opposed to being shameful or awkward. I know when I teach beginning students, they somehow have an idea, I shouldn't say somehow, we inculcate, but they have an idea that the therapist must be perfect, must, have genuine positive regard for everyone they work with. They've read Rogers, they've taken it to heart. But in reality, we don't. We don't have that immediate, unconditional positive regard. In fact, we may very much have hostility feelings toward the patient, or we may want to take them out for a cup of coffee. It kind of runs the gamut. But being aware of those and practicing being in touch with those is part of really being a competent therapist.
So let's zoom in then on exercise number 2 from the book, being aware of countertransfer reactions. I'm sure a lot of people are now wondering, but how do you do it, right? And that's kind of the magic of the little practice, is really drilling down into how do we do this. So Hannah, you want to run us by the 3 skill criteria that you devised for this exercise?
Right. So first of all, it's observing and tracking your own thoughts, feelings, wishes, physical sensations, and urges, behavioral urges, while simultaneously listening to the patient. This is a very difficult skill. It sounds fairly straightforward, but to be able to listen to the patient and listen to yourself, that is a very complex set of skills. So we're going to practice it so that when we are sitting in front of a patient, we can do it much more easily. Secondly, for the purposes of this exercise, we usually work in pairs in doing these exercises, but you could certainly do this one on your own. You disclose the reactions to your partner that you feel comfortable sharing. And of course, it's okay not to disclose as well. When you're sitting in the privacy of your own office or home, much easier to disclose these reactions. And we do say them out loud. It's one thing having them in your head. They're so much more elegant and make so much more coherent sense in our heads. But actually saying them out loud, we may even begin to hear that there's emotion in our verbiage. So that would be criterion number 2.
And Hannah, just to emphasize something you pointed out, this is not practicing to disclose those reactions to the actual client when you see the client, correct?
Yes, we thought about doing that skill in this book, but because it was conceived of as kind of a beginning book, we decided not to put in that very complex skill of then how do you share and when do you share your countertransference? When will it be therapeutically useful? We do have, however, if I can just make a little side comment, we do have exercise 11, however, way toward the end, using supervision to recognize reenactments. And in this exercise, we are actually having the trainee practice saying to a supervisor, a reenacted role-played supervisor, of course, saying to this supervisor what their countertransference is, what's given rise to it, and then getting the supervisor's imagined responses back. And we've included that exercise because it's so important to use supervision to help manage these countertransferential reactions. But for this beginning exercise number 2, We are just saying it out loud to inform ourselves and to track our own reactions. And the third category is if you're having reactions in the too hard category, and we'll explain that, then you can ask the trainer or your partner to make the role play easier. Here I might say, if you're having reactions in the too hard category, you just might want to sit this example out.
Right. So Hannah, you wanted to mention about the reactions here as well?
I do. So as you can see on the vertical axis to the left, we're looking at thoughts and emotions, bodily reactions, and urges. And then we have these two columns, the good challenge and the too hard challenge. And in deliberate practice, we want to stay within that good challenge range. In other words, if you're not feeling these kinds of things and you're kind of bored and tuned out, chances are the challenge isn't enlivening enough. So here are the kinds of responses you might have in a good challenge. You may get anxious, frustrated, annoyed, irritated, disappointed, manageable self-judgment, some shame, even embarrassment, self-doubt, manageable anger, sadness, guilt, longing, etc. So those are some thoughts and emotions. Now, if that shifts into what we call the too hard category, then the exercise is too overwhelming, and you need to make the exercise, the stimuli, less gripping. And so here are some of the responses in the too hard category: hopelessness, helplessness, severe self-judgment, intense shame, a lot of embarrassment, much self-doubt, overwhelming rage, grief, guilt, intense longing. So if you find you're going into those categories with regard to thoughts and emotions, too overwhelming, back down. We like to be in what's called the zone of proximal development, which means it's in that sweet spot. Not too easy, not too hard, sometimes called the Goldilocks effect. Now, if we look at the next row of body reactions, so in the good challenge, you could have body tension, clenching or jittery teeth, it's okay, shaky hands, shallow breath, a dry mouth, increased heart rate, all in the good challenge. But if you're getting a migraine, if you're becoming dizzy, if you're having foggy thinking, diarrhea, constipation, dissociation, nausea, acid reflux, any of these, too hard. Back off. And finally, the last row, urges, behavioral urges like looking away, withdrawing, changing the focus. These are all normal, good challenges, but too hard would be really shutting down and giving up, right? And that goes across all of the exercises, not just with regard to countertransference.
Maybe also important to add here, Hannah, that there is quite a subjective quality to this, whereas one person might find one client statement very challenging, even overwhelming, and another person might find it quite easy, and vice versa, correct? It really depends also on the trainee who's practicing in their own subjective developmental history, etc.
Absolutely, right. Thank you.
Very well. Okay, so how do we actually practice this? So we have the skill criteria, these 3 numbered statements here that Hannah read. We're tracking the intensity of our reactions to make sure we're practicing at the right level. So let's actually try this out together. Let's do together a deliberate practice exercise. And I want to again say, it's totally okay to not participate, although of course we would love it if you'd like to do it. The way we're going to do this is I will read out loud a patient statement. So imagine that I am your patient. Imagine being in front of this patient and what kinds of reactions. Try tracking the reactions you might have to this patient, be it thoughts, feelings, wishes, physical sensations, and urges. If you are comfortable disclosing any of your reactions, and again, only if you are, feel free to put them on the Zoom chat, right? And of course, if it feels a little bit overwhelming, back off, no problem, right? So let me read this client statement. My parents have been trying to fix me ever since I was born. My teeth were a little crooked, so they got me braces. They were concerned about my weight, so, did I tell you that my dad is a diet doctor and my mother is petite? So they made me keep track of every single thing that went into my mouth. I didn't really like that very much. They'd still be trying to fix me to this day if I let them. I'm pretty complex. You're looking at me like I'm from the moon or something. Why don't we meet 2 or 3 times a week so you can figure me out and tell me what I need to do to move forward with my life? All right. If you want, feel free to read that back. And if you're comfortable, feel free to disclose any thoughts, feelings, wishes, physical sensations, and urges you might have had.
Great. There's a bunch of reactions coming in right away. I put my reactions in the chat. And what we're seeing is a mix. I'll just read it, a sampling. There's some physical sensations like tension in the stomach, hands. There's some feelings like annoyance or sadness. There's urges to help the client, urges to slow the client down. There's a few people mentioned anxiety. There's urges to validate. So what we're seeing is actually a pretty broad range of reactions. In fact, no two reactions were the same as far as I've seen so far. How does this square, Hannah, with your experience in the literature?
Right. Well, yeah, I am seeing some similarities here. But yes, the people can have very unique responses depending upon their familiarity with the situation, with issues within themselves, other clients, etc. And yet sometimes when that interactive countertransference is really powerful and strong, when the presentation has so much pull and push to it, you do find commonalities, especially when people together, like in a group supervision, can begin talking about the client. And then you find, oh yeah, I had that reaction too. I was afraid to say it, or I wasn't aware of it. And so sometimes when the presentation is so powerful, you do find some overlap. But the reason for doing this exercise is really just to get in touch with whatever is going on. And these are wonderful responses.
Yeah, now I'm looking, I have seen a bunch of people say confusion has come up a number of times. And so I just want to emphasize something. I think you're saying the goal is not to fix the reactions or solve the reactions or resolve the reactions like I thought I was supposed to do when I was first learning therapy. I was like, oh, this is something to get rid of, right?
Right. Yeah. No, that isn't it at all. In fact, when we take a look at what the research has to say about beginning trainees, they are not talking about their countertransference, especially the countertransference that might be embarrassing or shameful, right? They're not talking about that countertransference in supervision, which is dangerous, right? Then it all goes underground. Then the likelihood of reenacting it, doing something that isn't in the patient's best behalf goes up.
So part of
this
the goal, go ahead.
So this isn't about managing anything. This is about becoming aware.
Got it. Great.
Great. So yeah, it's kind of a naive social psychology experiment we're doing here, because we can definitely see people having different reactions. And as we know, those reactions would probably lead them in different behavioral interactions with their clients. So very relevant to be aware of those reactions. Also, just a reminder, if you are using this exercise or if you're using it for your trainees or with your trainees, remember that it is always great to give them the option to not disclose any of these reactions. Remember the very strong power dynamics and differentials that exist in supervision, and it's definitely helpful enough for the trainee to do the exercise without disclosing their reactions.
Yeah, something I will often tell my supervisees is the goal is not for me, your supervisor, to learn all your reactions. The goal is for you, the supervisee, to become self-aware of your reactions.
Right. And of course, when you're working in supervision, what you do have are not these, I won't say artificial, but constructed patient presentations. You've got your real patients that you're talking about, or even more stimulating, watching on a video, right? So this becomes very evocative and, of course, very clinically relevant. There's your patient.
So I'm excited because normally we would just be using this system where one person plays the patient, the other kind of does the exercise. But today we have a little treat. Today we're doing something a little bit different. So we're not just going to be using these written statements, but actually we have some video stimuli. So what I'm going to do is I actually am going to play a video stimuli. So this is an actor playing as a client. So as you see the actor playing as the client until the end of the clip, do the same exercise. Track your thoughts, feelings, wishes in reaction to this client. Pretend that this is your client, that you're in a real session with this client, and try tracking your reactions, okay? And then if you're comfortable, you can disclose any in the Zoom chat. All right, let's see the first clip.
My doctor says I should come see you. He thinks I have a drinking problem. But he's a liar. Everyone drinks. And I can control my drinking. My boss, when he fired me, he blamed it on my drinking, but really, he was looking for an excuse to fire me all these years. Well, when our car got smashed and our daughter got hurt, my wife blames it on me just because I had had a few beers beforehand. But that was really not at all the issue. There was a guy driving in front of us, and this is why we crashed, you know. Being drunk doesn't affect my driving. I was totally in control.
Hey, take a breath. And if you're comfortable, feel free to write any reactions on the chat.
Great. We're again getting a diversity of responses that seem pretty as one would expect for a client who might be in pre-contemplation stage of change. This is not an uncommon clinical presentation, especially in some work settings. And the goal here is to help, especially trainees, but really everyone, help get some experience being self-aware, ideally before we're sitting with clients that present this way. Hannah, what do you think of the responses we're getting so far?
Yeah, there's certainly a lot more commonality, right? A lot of annoyance, a lot of doubt about, can I really be of help to this person? Some sadness, a sense of being manipulated. So we are seeing some consistency here, which we would expect.
And I so appreciate everyone sharing what might be less socially acceptable reactions, I should say. Of course, I don't believe that. But like, we as perfect therapists, of course, never get upset with our clients or annoyed with them, right? But of course we do. So it's great that we can be compassionate about those normal reactions.
Yeah, I remember in my first years of training, I was helping clients who were in a pre-contemplative state of change with pretty serious addictions. And I had studied motivational interviewing and I knew the techniques, but I kept having the moment I'd sit down with a client like this, I'd just find myself arguing with them and trying to convince them that they had a drinking problem. And you can imagine how well that panned out. And I just no awareness of my reaction. I get swept up in it. And later on, when I watched the video, I could see it, but it actually took a lot of practice to start to be aware of it as it happens.
Yeah, right. Right. That's a really excellent point, Tony. The awareness of in the moment versus after the moment, right? Yeah.
Great. I mean, let's keep the ball rolling. We have a good practice going. Let's do just 2 more. So back to a written statement, and then we'll finish off with another video. All right, let me get into my patient role here. Again, imagine this is your patient in front of you. Yeah, my doctor sent me here because he thought it might be helpful with my high blood pressure, but I get stressed for real reasons. It mainly comes from needing to work under people who are not very good at their jobs. Either they're not that bright or they're really not that committed. People tend to be intimidated by me because of my accomplishments. I got perfect SATs, graduated from college in 3 years with honors. I have to tell you, I have my doubts about seeing someone like you here at the clinic. Do you really have enough experience to be of help to me? All right. Let's give everyone a minute.
Great. So again, we're seeing a trend in the responses, but in a kind of a different category, you might call it, compared to the previous client.
Hannah, any reactions to the reactions?
Right, right. Yeah, the defense, the contempt, frustration, anger. Yeah. Right. I like the emphasis here, the constriction in my chest. I think sometimes tuning into those sensations without putting words on it can be very, very helpful at this level. By the time we get to words, we're already foreshortening the experience, so to
Luca,
speak.
du skal være færdig nu, skat.
So Hannah, is kind of what you're saying that it's like I mean, it's good that people are writing down the reactions, or when they would practice themselves, we'd want them to say it out loud. But this is valuable even if you have trouble verbalizing it, even if it's just some experience that's kind of hard to label or categorize.
Right, right. Especially maybe, right? Because then that has the chance to maybe seep into the work kind of unnoticed. So here being really in touch with, oh, my stomach is clenching. My hands are in a fist. I'm sweating. I'm, feeling somehow uncomfortable in my skin. Just those kinds of vague somatic responses are extremely important to tune into. Yeah. And if those of you that do meditation or body scans or some version of this will recognize that quite often the emphasis is on just recognizing what's going on without labeling, without judging, and becoming aware. And that's a very effective way to use this exercise.
Though it is pretty vulnerable, right? For especially a trainee, to like have a feeling that's not really clear. I know when I was a trainee, we talk so much in therapist training about competence.
Yes.
Right? And achieving competence. And what we're doing with this exercise is really kind of different, isn't it?
Yeah, when I start off with my new trainees, I very much like showing videos of myself where you can clearly see that I'm enacting feelings that I'm having, right? And there it is. And is that the way to do therapy? Well, I don't think we're going to read in any textbooks. Yes, please enact with your patient. But it happens, right? And I think it's so important that we destigmatize this. I mean, it started off with Freud's writing about it in that way. And truthfully, for decades, no one really took a look at it the way we're taking a look at it now in contemporary psychodynamic thinking. Yeah.
So this is kind of like taking responsibility, like proactively taking responsibility for your inner world as a therapist.
Yeah, I mean, you have the instrument, right? Oh, and speaking of which, I'm going to give a little shout out here. This is Tony's book, an earlier book that he wrote, and the whole book is focused on what are called inner skills, kind of like one of the ones we're working on now. So just if you're interested in this, here's a whole book on it.
Thank you, Hannah. What I really love about your book, Hannah, is it's really situated in a model. So in my book, it was more kind of open, common factors. And what I have found since publishing that book is many trainees feel more comfortable training within a model, because the model gives a real framework. It's not just like, oh, I'm lost in all these feelings. It's like, okay, this is why I'm looking at my feelings. This is how it's going to help me help the client. There's a whole kind of map involved.
Right. And in fact, later on in one of the other exercises, we focus on formulation. And I always add in, as part of the formulation, what is your countertransferential reaction? Right, because that has to make sense in terms of the formulation.
Great.
So if it's okay, we have one last video. And I should say, before we watch this video, I think this is a best of, like when Tony and I started doing these with actors, we quickly found that the video you're about to watch became probably the most seen video we created for a long time, and you'll soon see why. We know that teachers have used this video across the world, so be gentle with whatever reactions you have. We will have some fun, I'm sure. And it's the same exercise as always, right? The video is almost 2 minutes long, a bit less than that. So track feelings, thoughts, wishes, physical sensations, and urges. Feel free to disclose or not disclose any reactions, okay? And again, this is your client. You're in front of your client, and this is what happens.
I want you to know that
You've been very helpful to me. We have only been meeting for a few weeks, and you've helped me way more than my previous therapists. How do you understand me so well? It's like you can read my mind. You're very insightful. What I'm thinking about right now. It's a shame that I met you as my therapist, because you're the kind of person I've been looking for as a partner. Sometimes I wonder what it would be like if we were together. The other night I hooked up with a girl I met at a bar. And when we were together, I thought about you. I hope you don't judge me for thinking about you. And I know you have to be professional, but sometimes I wonder if you think about me too. I know you can't answer me that, and that's okay. Because honestly, it's more fun having a secret, isn't it?
Okay. So let's give people a minute. Anyone want to share reactions?
Yeah,
Yeah.
this video often has strong reactions. Yeah.
Right.
Okay, so we're seeing again a common trend in the reactions.
I really appreciate everyone's coming forward like this, in a
Me too.
public forum. Alex and I and Tony discussed, this is, how is this exercise going to work for the demonstration? I just really want to sincerely thank everyone for
Yes.
participating as you are.
Also feels like a very compassionate support group that we can all just share normal reactions that we have.
I remember the first time a client expressed attraction to me in a session as a trainee, I completely froze. I basically disassociated. And you remember the reaction form we were showing earlier with the, good challenge, too hard. It was definitely in the too hard category. And of course, because I froze, I wasn't able to set really clear, good boundaries. Instead, I just kind of pretended she hadn't said anything.
Yeah.
And then I was terrified of telling my supervisor, somehow I had done something wrong. And so if we had watched this video in my training or in group supervision or something beforehand, it would have just prepared me a bit for this situation.
Yeah, one common reaction we found to this particular video is the shutting down or almost dissociative element, where at a certain point you just stop listening or stop looking, right? And that's a normal reaction to have, and it's trainable to stay with that. People are still writing the reactions. Great. Hannah, anything you want to add to this?
Well, I think all the points that you're raising, of course, again, I'm keep going back to the research. I like doing research as well as clinical work. And the research shows that therapists, especially trainees, have much more difficulty with erotic transference than they do with hostility, narcissism, almost just about any other presentation, at least in our culture.
Yeah, I'm glad you bring up culture, Hannah, because this exercise, well, all the exercises are going to be very culturally dependent, but this one especially. And I really like how you and your team crafted the exercise to make it very flexible. It can be, you know, it can be used in cultures around the world and be very responsive to that culture. And this is something for supervisors to keep in mind when you're doing cross-cultural supervision, as I know many of us do, to really be open to the wide variation of reactions in culture. Also, different trainees from different cultures will have different levels of comfort sharing this material. And so this is another reason to really explicitly give trainees permission to not share, but instead just be self-aware.
Right. Alex and I had a discussion about, you know, what would be most provocative, what would, you know, really bring out these countertransferential reactions. Would it be having the verbiage and just having the person create an image of the patient? Or would it be actually showing, you know, the physicality of the patient on a video? So we're kind of curious to get some feedback about that.
Yeah, if anyone would be comfortable, can you tell us which felt more evocative? Was it the reading a client statement, a written statement, or was it watching the video or videos?
Of course, we do have a little confounding here of the intensity that we might not have equated for all of that throughout, but nonetheless.
It looks like the videos are the winner.
They usually are. And as I said earlier, watching your own client, right? There's nothing really better than that. If you're struggling with a client and you're having, you're not sure what kinds of feelings and you're struggling and it's not going so well, something's happening interpersonally that isn't feeling therapeutic, watching a video of that client and just letting it play. And as it's playing, you just saying out loud what the feelings are as they come up can be extremely helpful.
Yeah, I love Tim has the saying because we're in the age of telehealth. It's even better to use these videos because you can just really pretend it's a client in front of you.
Very good point. Very good point. Yes. Yeah.
I'm going to I'm putting a link in the chat, and this is a page on our site where there's a lot more videos like this. And everyone is welcome to use these videos in your own supervision, in your own training, your own teaching, however you want.
I should also make a funny sidebar that I once started using these skills years ago with just freely available YouTube videos, including therapy videos that are freely available on YouTube. Many of you know about the Gloria tapes, Gloria seeing Carl Rogers, Albert Ellis, and Fritz Perls. It's all full therapies in the YouTube. So using this exercise with those was very helpful. I realized though that I had much stronger countertransference reactions to Fritz Perls, the therapist, than the client Gloria. So staying with Perls was actually much harder and much more evocative. But you learn. That's how you learn.
And actually, Gloria had much stronger reactions to Fritz Perls too.
So very validating. Great.
Do you want to take any questions before we end? How would you like to do this?
Yeah, anyone have any questions for Hannah or
comments, you know, just.
It's pretty cool. It's like we've got a nice learning community here. Everyone's been really participating today. Something I want to mention is we have, oh, there's a question from Lauren, please.
I don't want to cut off your comment either, Tony,
Please.
but
No.
Thank you. Yeah, no, I came in a little late to today's training, so I apologize if my question might have been covered by this earlier in the intro, but I am intrigued by, I've always been intrigued, you know, by your framework of, you know, deliberate practice. I remember, you know, learning from you all first at a CEPI convention, and one of your workshops. And so Dr. Levinson, of course, you and your work, your seminal work in our field as well. I just really appreciate, this being created, first of all, and offered to us. My question being, it was mentioned earlier that the most, or maybe one of the first foremost steps of this is, of course, building our awareness of our countertransference reactions in the first place. And I do have the deliberate practice book on that was released, that was mentioned earlier too, and I still have to make my way through it. And so I'm wondering, if in that book or if there's other resources about how to then manage the reactions themselves. I know I'm probably jumping ahead of myself of, first got to build the awareness and then manage the reactions themselves. But I guess my question being inherently in the management of these.
Oh, that's a wonderful question about the management. And now, in the past 30 years, we've got some really good work having to do with ways, exercises, procedures, supervision, suggestions about how to handle and manage those responses. I myself have tried to write some of those deliberate practice exercise about managing those responses and using them. I think the work on rupture and repair by Eubanks et al. Is excellent in that regard. And I know they are also working on honing in on skills specific to, interpersonal sensitivity and how to handle those ruptures to make successful repairs. So all of that, I think, is a gold mine of worth investigating. Thank you for that question.
That was a great question. Thank you, Lauren. So Susanna had a great question. Is it common practice to record your client during sessions? And the answer is, it depends. It is increasingly common. I was almost fired from a site 20 odd years ago for suggesting they record sessions. But as time is going on, more and more training sites and more postgraduate, just therapists pursuing ongoing training or recording sessions. At Sentio, our practicum site, our training site, 100% of therapy sessions are videotaped and 100% of supervision sessions are videotaped. So, because we really think that the best way to get a very accurate view of what's going on in therapy and supervision is through the video. Now, of course, it has to be done in a way that is appropriately secure and all that stuff, but that technology is available.
And I think creating an atmosphere where that is safe, right? I have sat in on many of those supervision sessions, and it making the whole procedure safe enough so that people can come forward and show their video work, especially supervision, which is, the last, I've done some writing on that, and I call it the last closet of psychotherapy. Now we've got lots of tapes of therapists doing therapy, but very few of supervisors doing supervision, and there's a lot to be learned. So I myself don't supervise unless I can supervise with a video. You just don't get the best of me without really looking at the nitty-gritty of what goes on.
Yeah, once you supervise with video, it's hard to go back.
Okay, thank you.
Thank you for the question. I think we are running out of time.
Just about.
So why don't we wrap up here? We put some links in the chat. Everyone is invited to attend our next webinar with Hannah, which will be March 25th. And you can register at our website, and we will continue our series. So I want to thank Hannah, first of all, for being here and sharing your experience and your wisdom with us. The group has clearly benefited so much from you. And I'd like to extend a special thanks to everyone for joining us today and participating and sharing your reactions today. We really had a very lively group, and it's really cool.
This webinar is made possible by the Sentio Marriage and Family Therapy Program. Visit us at www.sentio.org.